Thank you for organizing this. I think these are very important topics. I have to disagree with you, Daniel. We are not in time. In fact, my time's already up, technically. And I obviously want to give some time to my friend Serge Poveda in the final talk. I think we will be rather quick with my talk because some of this will be overlapping with what Gianluca and Thomas have been elegantly alluding to in their previous presentations. I will be focusing primarily on the value of remote monitoring with the life vest. And I would just like to quickly start with a raise of hands here. Who has used the life vest of you? Who has prescribed this to their patients? Okay, terrific. Who has been using the life vest network for remote monitoring of their patients? Some, but definitely not all. So I'm likely, or I hope I'll be able to convince you not only that the life vest is a good thing, which the previous speakers have done, but also that there is a value of remote monitoring. This is my disclosure slide. We'll go through the wear-it data really quickly because this has been alluded to twice now. We'll have an overview of the life vest network, and then we'll see some very brief cases where there are some interesting findings. Now again, the wear-it 2, for the sake of time, I will jump over this because this has been shown before. It's also been shown that the majority of these patients, as you can see here, did 1 out of 14, 17.4%, were diagnosed with an arrhythmia that required an intervention, be it a sustained VT-VF, non-sustained VT, or any type of other arrhythmias that may be of clinical value during the time. So obviously, if you wanted to calculate the number needed to treat, and Daniel was alluding to the percentage and the denominator of that percentage earlier, this is what you come up with. If you were to treat your next 100 patients with the defibrillator, you would have 2 patients that will experience a sustained VT-VF, and one of them which will self-terminate. You'll have 1 patient that will have a non-sustained VT, likely a candidate for possibly an EP study, which is at least likely what we do at our center, and would implant if he's a candidate. But you'll also have 4 patients with supraventricular arrhythmias, which you can then evaluate further, and 1 patient to survive asystole, which you can obviously also then evaluate later. This is the outcomes. We've seen this. I will drop over this, and I will get to the remote patient data management with the life vest network. This is actually a very interesting and very useful tool that comes along with the life vest, and that not only in this crowd here, but also at home, for that matter in our country, where we see this underused. There's automatic recording of several important events, not only shock treatment, but also arrhythmias that are detected and not treated. So non-sustained VT-VF, non-sustained or sustained supraventricular arrhythmias, or even bradycardia that meet the asystole criteria or plain asystole. Obviously, in addition to also artifacts that will also show up on this network. This is basically how it works. It's very much similar to other remote monitoring systems that you know from other implantable cardiac devices. The patient that is wearing the life vest has this transmitter that is then transmitting this to a secure server. You have access to this just like you would do with any other type of remote monitoring, be it CareLink, be it Merlinet, be it whatever. The prescribing physician then takes a look at this and performs reasonable actions. Why I'm saying this is because, as we've seen in many of the outcome studies for remote monitoring, this is a crucial step. Just the mere fact that there is a remote monitoring system doesn't necessarily mean that the patient actually profits of it. There are many chains in the link where things can go wrong. We've seen this in some of the remote monitoring studies. We've also seen in some of the remote monitoring studies where things can go right. For example, in the InTime study, where there was a mortality benefit by adding remote monitoring to these patients. There are 2 ways in which this can be transmitted. Number 1, if there is a shock delivery of the life vest, there will be immediate transmission to the server. And in all other events, there will be a routine transmission, which is once per day. So you have to have a system in place. We, for example, have a dedicated nurse that is taking a look at all the remote monitoring transmissions from all the manufacturers, including the life vest, every day to see if there's anything ongoing that needs to be taken care of. For those of you who have had their hands on the system, this is what it looks like, your dashboard page where you have your patients. You can also see who is usually taking care of this patient, because it's virtually impossible for you to take care of all of those also on a clinical level. But you have the name of the treating physician that you know that you need to call whenever there is an action. Also and this is a very useful tool in my eyes, there is a possibility of tailoring your notifications and tailoring what you want to know about the patient. If you know that this is a patient who every once in a while has atrial fibrillation may be known, you can put this alert to a lower degree such that your inbox is not going to be filled every morning with things that you already know. So it really gives you the possibility to record or to take a look at ECG recordings that are transmitted both manually and automatically by the patient, and these are again the type of informations that are being captured. The one thing that I find extremely useful, in addition to what has been said before, the arrhythmias, the non-life-threatening arrhythmias, is in fact the monitoring of the patient compliance. Because like in any medical treatment, like when patients are supposed to be taking pills, pills don't work in patients that don't take it. Same thing for the life vest. Life vest won't use in a patient that's not wearing it. And it is a very useful way of checking how compliant the patient has been, how much of the time during the day he or she has been wearing the life vest. As you can see, there are some pauses here when they likely took a shower, but other than that, here he didn't shower that day or he left the life vest on. So it's a very good way of getting an idea, and this is the ideal situation. In some patients, we see that they just simply stop wearing it, and then, maybe 4 days later, they put it on for a day, then they leave it off for a week or so, and that's obviously not what you want. So again, reasonable way for call for action, call the patient, see what's going on. Sometimes it's that, for example, they lose weight, they gain weight, whatever happens, the life vest doesn't fit anymore very well, and they just simply take it off instead of saying something. And I can only say this from my country. There, I have to say, Zoll has been very helpful in supporting these patients to really going to the patient, checking what's wrong, and possibly adapting the life vest. But really seeing or realizing that there is a problem in terms of compliance is probably the most important step in this situation, because otherwise we will miss those that will then eventually need therapy. And just to finish up, 3 nice case examples, I think, of where we weren't dealing with a life-threatening VT or VF, like the one that Thomas was just showing, that really looks scary. This is obviously not VF, this is asystole. So that patient had asystole. You can see the swipe speed right here. There's some action here, some escape rhythm, and then there's really nothing going on. Likely, the way it looks from this one-lead ECG is a 6 sinus. Whatever, could also be neurocardiogenic, but anyways, there's nothing going on. So this was something, the patient had syncope, and we can easily correlate this to this. The same thing, the other way around, a patient with palpitations. So normal ECG on top, lower ECG at the time when the patient felt palpitations. You look at the life vest network at this point in time, and what you see is indeed atrial fibrillation that had not been diagnosed before. So there really is some value, even in the sense that it works not only as a variable defibrillator, but also in a way as a like an not implantable loop recorder in many ways. And then finally, obviously, those types of events that patients are able to suppress themselves. Because as you know, there is a way that the patient can actually suppress the delivery of therapy. It's an extremely loud sound, so there's hardly a way. Some patients apparently have slept through that and then have received a shock. I can hardly imagine this. This is a very loud sound. If the patient doesn't have syncope, he or she can suppress therapy. Nevertheless, you will see what was going on. So in this case, for example, monomorphic VT, which was detected, which could be adequately treated, which may prompt you to implant an ICD at the end of the day, or go for ablation, medical therapy, whatever you want to do. So there is some use, some added use in also seeing therapies, events that are actually not have led to therapy. So in conclusion, ladies and gentlemen, as we've seen, there is a substantial amount of patients that is being treated in the rare registry, same for the German registry, treated for possibly life-threatening arrhythmias. The other good news, as we said before, but worthwhile to say again, a substantial amount of patients, over 40%, eventually did not need the ICD afterwards. So whenever we talk about cost, of course the life vest is not for free, for sure not. But when we talk about cost effectiveness, we have to take everything into the balance, not only the cost of the device, also the cost that is possibly saved. And for this is an important piece of information. The LifeVest network is of additional value in my eyes. First and foremost, with respect to compliance. I think for this we have a good reasoning that this may play an important role. With respect to the other arrhythmias, it may be useful. However, I would also issue a word of caution with respect to what to do with these patients. If it is asystole, for example, in a setting of neurocardiogenic syncope, we're not completely sure what to do. If this is subclinical atrial fibrillation, we're also not completely sure what to do. If we need to anticoagulate, if not. So really to really evaluate the additional value of what you can see in terms of other arrhythmias, we will need further study. We need to do more work in order to also assess what the consequences should be in terms of clinical action. Thank you very much for your attention.